Welcome, everyone. My name is Christine Marie George, and I'm an associate professor at Johns Hopkins. It's my pleasure to welcome you to our side session on leveraging mobile health for a transformative WASH. And today I'll be presenting on the findings from our randomized control trial of the CHOBI-7 mobile health program. This is the first WASH mobile health program randomized control trial that's been conducted. This study is a collaboration between my research group at Johns Hopkins and the Bangladesh Ministry of Health and Family Welfare, as well as the International Center for Diarrheal Disease Research, Bangladesh. And so I'll begin by going through our study rationale. When a household member, when a cholera patient presents at a health facility, their household members are at 100 times higher risk than the general population of developing a cholera infection during the 7 days after the patient is initially admitted to the health facility. And this is thought to be because cholera patient household members are sharing the same contaminated environmental sources, such as drinking water, and also through person-to-person transmission, for example, through poor hygiene practices in the home. And the high risk of subsequent diarrheal diseases for the household members of diarrhea patients expands beyond cholera to other enteric diseases, such as shigellosis and enterotoxigenic E. coli. However, despite this evidence, there's very limited interventions for this high-risk population. And this led our research group to the development of the cholera hospital-based intervention for 7 days. And the acronym is CHOBI-7. CHOBI means picture in Bangla for the pictorial modules that are delivered as part of this program. And 7 is for the 7-day high-risk period for the household members of diarrhea patients after the diarrhea patient is initially admitted to the health facility. The CHOBI-7 program is health facility initiated. It's initially delivered bedside to the diarrhea patient and their accompanying household members during the time of treatment. And the WASH modules are on hand washing with soap at stool and food related events, as well as water treatment and safe water storage. The behavioral recommendations that are promoted during the health facility visit are then reinforced through home visits. In our initial randomized control trial, the CHOBI-7 intervention, and so this was the initial version of the intervention before we added the mHealth component, we found that delivery of this intervention to cholera patient households resulted in a significant reduction in cholera among the household members of cholera patients. And in fact, there was a 47% reduction in overall cholera infections among the household members of cholera patients. The promising findings from this study were shared with the Bangladesh Ministry of Health and Family Welfare. And they expressed an interest in scaling the CHOBI-7 intervention across Bangladesh. However, they asked us to make some modifications. First, they asked us to broaden the scope of the intervention to include diarrhea patients of all etiologies, not just those with cholera, given the evidence that there's many enteric pathogens for which the household members of diarrhea patients are at higher risk of developing subsequent diarrheal disease. In addition, they asked us to investigate scalable approaches for program delivery that did not involve home visits, since home visits were not an approach that the government could take to scale. And so this led to a grant submission to USAID to the Development Innovation Ventures program that was funded in 2016 and led to our current work, which is the CHOBI-7 Mobile Health Program. Mobile health presents a promising approach to deliver public health information in Bangladesh, given the high mobile phone coverage in the country. To date, there are over 160 million phone numbers registered in the government's database. In addition, our recent mobile health surveys found that even in some areas of Dhaka, over 90% of households reported ownership of an active mobile phone. And so this led us to our current work. And for the next part of our presentation, I would like to introduce Fatima Zora, who is an assistant scientist at ICDDRB, and she is the intervention lead for the CHOBI-7 mobile health program, as well as Elizabeth Thomas, who was a senior research data analyst with our group. And she led our formative research for the development of the CHOBI-7 intervention. And so in the next slides, They'll go through the findings from our formative research and how this informed the final version of the intervention that we implemented as part of the randomized control trial. Thank you.
Great, thanks, Christine Marie. And I'm going to get us briefly started on the formative research and intervention development for the CHOBI-7 mobile health program. So we conducted extensive formative research to work on adapting that initial CHOBI-7 intervention for a more scalable approach and to incorporate that mHealth component. And in order to do so, we explored existing WASH practices both in the hospital and the home through semi-structured interviews with government stakeholders and caregivers of young children and group discussions with caregivers of young children. And then we piloted our developed intervention in 52 households with diarrhea patients and their household members to get a better sense of user experiences and preferences with receiving a mobile health intervention in this setting. And the formative research is detailed in the 2 publications that you see listed at the bottom of this slide. So we work to promote 3 key behaviors during our mHealth program. The first was hand washing with soap, and specifically we promoted hand washing with soapy water as a low-cost alternative to bar soap. And it's made by combining water and detergent powder in a plastic bottle. We also promoted water treatment, first using chlorine tablets during the 7-day high-risk period for diarrhea transmission between patients and their household members, and boiling of drinking water thereafter. And finally, we promoted safe water storage for drinking water in a covered water vessel with a tap for access. And based on our formative research, we made 2 key design decisions for the mHealth component of the intervention. We decided to include both voice and text messages, which were delivered weekly over the intervention period for 12 months using the Viamo platform. And second, we decided to include 3 study characters to help deliver the intervention. And these were modeled after UNICEF's MENA characters, so they each had their own stories and personalities as they delivered the intervention. Dr. Chobi, who was the central character for our intervention, is seen on the left here, and she's a physician at a diarrhea hospital, and she meets diarrhea patients and provides recommendations and encouragement to adopt the 3 key behaviors for our program. You can also see our middle character is Aklima, who's the mother of a, young child who comes to the hospital, and the child has diarrhea, and she meets, I'm sorry, this slide keeps going back. Aklima meets Dr. Chobi and receives recommendations to adopt protective WASH behaviors. And finally, we included Aklima's husband, who you see on the right here, as a peer role model for male household members to encourage them to participate in the recommended WASH behaviors as well. So I'll now talk you through 3 examples of the message content that we developed based on the formative research. Based on our findings, we learned that it was important to encourage self-efficacy for our WASH behaviors, as well as message sharing in the household. So here you see that Dr. Chobi is calling a household member who's had diarrhea and has been discharged in the last week. And she's asking that household member if they're using soapy water. She then reminds them how to make soapy water and that it's easy. And she encourages them to keep working to do so. Here we see another example with Aklima, and here we had interactive messages. So Dr. Chobi would call a household member and ask a question, and the household member, free of charge, would be able to respond to a message by pressing 1 or 2. And here you see that Dr. Chobi has asked for help reminding Aklima how to boil water so that it's safe for consumption. The household member can press 1 or 2 depending on what they think, and then Aklima chimes in and thanks that household member for their help. And finally, we have an example with Aklima's husband, where again, he is serving as a male role model for diarrhea patients and their household members. And here, Dr. Chobi is calling Aklima's husband, asking how he's doing, how the children in the household are doing. And he then says, my children are fine now that I've adopted the recommendations that you've given me. And then she encourages Aklima's husband to share the messages that he's received with other household members. I'm now going to turn this over to Fatima Zora, who's going to talk about some of the responses of our pilot households to the message content and how it was delivered. Thank you.
Thank you. Okay, thank you, Dr. Christine and Liz, for giving me this opportunity. So I'm going to share the findings of our qualitative research. So we piloted our mHealth program in 52 diarrhea patient households to explore their experiences with the intervention and received tremendous positive responses both for Dr. Chobi and Aklima. Dr. Chobi, the sender of mHealth messages, was viewed as a credible source of information. Participants followed each and every instructions by her as she is a medical doctor, and Aklima is like the other household members and she worked like an ambassador of Chobi 7. So you can see there are two quotes on the screen. So one participant said that she could feel her, Dr. Chobi's words from her heart. The other ones mentioned that Aklima was a patient like me, and it is good that she's taking help from Chobi Appa like us. She should promote all this knowledge to others. Oops. So now I'm talking about the message type. Here, we also learned that participants preferred both text and voice messages. As part of the mobile health, we found a positive response for both types served as reminders. Voice messages are valued for those that could not read, and text messages because it facilitated sharing, saying, I can show this message to 10 more people. The other participant mentioned about the feelings about the both messages like voice and text messages, why these are good. She said that both voice and text are good. From calls we can learn, and if sometimes we forget, we can see the message or tell others to read them for us. That is why both together are good. We had promoted message sharing and found that mobile messages were important for spreading awareness and improving health, as this participant said. Like Dr. Chobi says, we should wash our hands right after cleaning our children after toileting. If we do this, we would be free from all diseases. So this was just a brief set of examples of the developed voice and text messages and pilot study responses. Overall, we found that our program had high user acceptability and was feasible to deliver in the low setting areas like Dhaka slums areas. Both voice and text mobile messages can serve as valuable reminders to practice behavioral recommendations, especially WASH behaviors. mHealth presents a promising large number of households at minimal cost. So now I like to pass this to Dr. Christine. Thank you.
Thank you, Fatima. So now I'll go into the findings from our randomized control trial of the Chobi 7 mobile health program. And to those who just joined, I'm Christine Marie George, and I'm an associate professor at Johns Hopkins, and we're discussing the findings from the Chobi 7 mHealth program. And so to give you an overview, you've seen our formative research. And so the design for the delivery of this program is that, as I mentioned earlier, it's health facility initiated. A health promoter delivers a pictorial module bedside to the diarrhea patient and their accompanying household members in the health facility during the time of illness. In addition, during this health facility visit, diarrhea patient household members are provided with a diarrhea prevention package. And this includes a hand washing station with a lid and tap, as you can see here in red in the photo, as well as soapy water, which again is water and detergent powder, as well as a water vessel with lid and tap for safe water storage and chlorine tablets. And so after the diarrhea patient is discharged from the health facility, The diarrhea patient household then receives weekly voice and text messages for a 12-month period using the VMO platform. And so this includes the characters that Liz described earlier, Dr. Chobi, Aklima, and Aklima's husband. And so our randomized control trial of the Chobi-7 mHealth program was conducted between 2016 and 2019 in slum areas of Dhaka, Bangladesh. And so slum areas were defined as areas where people did not have a tap with running water inside of their home. We recruited diarrhea patients from 2 health facilities in Dhaka. One was Dhaka ICD-DRB Hospital, which is a large private hospital, and then Mukta General Hospital, which is a large government hospital in Bangladesh. Diarrhea patients were randomized to be in one of 3 arms based on the date that they were admitted to the health facility and the hospital ward that they were in. Over our study period, we recruited 769 diarrhea patients and 1,857 of their corresponding household members. Our first study arm was our standard arm, and this arm received the standard recommendation given in Bangladesh on the use of oral rehydration solution for dehydration. We had 2 mobile health arms. Our first mobile health arm received health facility delivery of the Chobi-7 program, as I described in the previous slide, along with weekly voice and text messages over a 12-month period. This arm had no home visits. And then in our second mobile health arm, they received the same intervention plus 2 home visits. And these home visits were conducted during the 7-day high-risk period after the diarrhea patient was admitted from the health facility. For evaluation of this program, we conducted monthly clinical surveillance visits in diarrhea patient households. Our child health outcomes were diarrhea prevalence, which was assessed monthly for children under 5 years of age. We also had stunting as a secondary outcome, and this was assessed through height and weight measurements collected at baseline and then a 12-month follow-up. We included intervention fidelity indicators. The first was receiving a Chobi-7 mHealth message in the past 2 weeks. And so this is from participant report. And then our second fidelity outcome was sharing of a mobile message from our program with others in the household and outside of the household. And so now I'll go into our study findings. We observed high fidelity of mobile message delivery for the Chobi-7 mHealth program. Even when we looked at our 12-month follow-up, which is here in red, we observed that over 78% of households reported receiving a message from the Chobi-7 mobile health program in the past 2 weeks. And this was the same between both of our mobile health arms. We also observed high message sharing during the 12-month program period, with over 75% of participants reporting sharing a message with a spouse, and then over 50% reporting sharing a message with a neighbor, which was a surprising finding, but showed that people really valued the mobile messages that they were receiving from the program and wanted to share them with others. In addition, nearly half of households reported sharing a mobile message with a child. Now I'll go into our health outcomes. We observed that delivery of the Chobi-7 mHealth program resulted in a significant reduction in diarrhea for children under 5 years of age in both of our mobile health arms. This was an 18% reduction in diarrhea prevalence in the mHealth with no home visits arm, and a 27% reduction in diarrhea prevalence for children under 5 years of age in the mHealth with 2 home visits arm. And I should note that this is diarrhea prevalence over the 12-month study period and was assessed through monthly clinical surveillance visits. We saw even larger reductions in pediatric diarrhea for children under 2 years of age, which is indicated here in red. This was a 22% reduction in the 12-month diarrhea prevalence for children in the mHealth with no home visits arm, and this was a 31% reduction in diarrhea for the 12-month program period in the mHealth with 2 home visits arm. Next, I'll go into our child growth findings. When we looked at our outcome of stunting for children under 5 years of age, we did not observe a significant reduction in stunting in either of our mobile health arms. However, when we looked at stunting in children under 2 years of age, which is the period for which children are most susceptible to growth faltering, we observed a significant reduction in stunting in both of our mobile health arms at our 12-month follow-up. We observed a 46% reduction in the odds of stunting in the mHealth with no home visits arm, and a 45% reduction in the odds of stunting for children under 2 years of age in our mHealth with 2 home visits arm. So to summarize our CHOBI-7 mobile health program findings, we found that delivery of this program over a 12-month period to diarrhea patient households resulted in a significant reduction in stunting for children under 2 years of age. We also observed a significant reduction in diarrhea for children under 5 years of age, and we observed high mobile message delivery during the program period, as well as high CHOBI-7 mobile message sharing. And importantly, we observed that even in the health facility delivery of the CHOBI-7 mHealth program arm that did not receive home visits, and so they received health facility delivery of the program plus weekly mobile health messages over 12 months, we saw that this was sufficient to reduce diarrhea and stunting among young children. And so in this slide, I'll go through some of the attributes that we think contributed to the success of the CHOBI-7 mobile health program. The first was the timing of delivery. This intervention was delivered to diarrhea patient households during the time of illness when someone had a severe diarrhea episode in the house. And this was likely a time where WASH behavioral recommendations resonated the most. Second, we were targeting a high-risk population living in some areas of Dhaka. When you look at the Bangladesh WASH benefit study, which was conducted in a rural setting, the diarrhea prevalence for children under 2 years of age was 6%, while for our population, the diarrhea prevalence for children under 2 was 25%. And so this represented a very high-risk population for enteric diseases and likely an environment that led to more room for WASH interventions to have a benefit. Next, the sender of our mobile messages. And so as Liz described during her presentation, we had a doctor from a known diarrhea hospital who delivered these text and voice messages. And we also had our other characters, and this was modeled off of Nina. And so we think that this approach also allowed the WASH behavioral recommendations to resonate with household members. And then finally, the type of mobile messages. So typically when people are delivering mobile health programs, they're either delivering voice or delivering text. But through our formative research, we identified that both were important. And so both were implemented as part of our program. And we think this contributed to the success of the program. So in conclusion, the CHOBI-7 mHealth program presents a promising approach to facilitate reduced pediatric diarrhea and improve child health among diarrhea patient households. And I'm happy to say that based on these findings, the Bangladesh Ministry of Health and Family Welfare has expressed an interest in scaling this program across the country. And so our current work is focusing on the scaling plan for this and also evaluating the impact of this intervention in rural areas of Bangladesh. And so I would also like to report that based on the findings from the CHOBI-7 mHealth program, we have expanded the scope of our activities and have recently set up a site in the Democratic Republic of the Congo, where we're leveraging our CHOBI-7 mHealth model to this setting. And so the name of the intervention that we're developing for diarrhea patient households in the Eastern DRC is the Preventative Intervention for Cholera for 7 days. And the acronym is PICHA-7. And PICHA means picture in Swahili, just as CHOBI means picture in Bangla. And then again, the 7 is for the 7-day high risk period. And this is also a targeted WASH intervention for the household members of diarrhea patients that's delivered bedside to the diarrhea patients and their accompanying household members. And here I just show our map of where we're located in South Kivu. And so we're currently conducting the formative research for this study. And we plan to start our randomized control trial of the PICHA-7 mobile health program early next year. And so that concludes my presentation today. I would like to acknowledge all of my study collaborators, which include our ICD-DRB principal investigator, Dr. Manirul Alam, as well as Dr. Manira, our partners at the Bangladesh Ministry of Health and Family Welfare that have contributed greatly to this work, as well as our evaluation team, which includes Ms. Tabina Parven, as well as Dr. Biswas and Dr. Tasdeek, who's contributed greatly, and also to Minhaj, who without him, the study wouldn't be possible, as well as our intervention team. You were able to meet Fatima Zora. I would like to also acknowledge Shahid Masood, who's presenting at this meeting, as well as my collaborators at Johns Hopkins, Dr. Jamie Perrin, who's here today, and is the biostatistician that has led the analysis of the findings from the RCT of this intervention, as well as Dr. David Sack and Dr. Alan Labreek. I would like to also acknowledge Shazal Islam, who's our data management lead, and he's actually presenting a poster tomorrow on the process evaluation for the implementation of the CHOVI-7 mHealth program. And I would like to acknowledge also our funding source, which was USAID for this work. And so that concludes our presentation for the side session. And so we would like to now open up the floor to questions. Thank you.
Please, if you do have questions, there's a chat box from the Pathable site where you can type any questions that you have. The chat for this Zoom meeting is disabled, so you won't be able to type any questions there, but you can use the chat box on the Pathable site. So far, we don't have any questions.
We welcome your questions, and I'll also put up a slide that has my email address here, so you can email me if you have additional questions.
Christine, I would have a question.
Great.
The really fascinating study, and it's great to see such positive impacts. And I'm wondering what you thought when you saw that the multiple home visits didn't make too much of a difference. Like, what was your sort of thought and takeaway, and were you surprised by that finding?
So initially we were surprised, but in a lot of ways, the mobile messages served as more frequent reminders. Most programs wouldn't be able to go weekly to households to provide behavioral recommendations, but mobile health really presents an approach that allows you to send out behavioral recommendations at low cost and more frequently.
So we do have a question. I'm sorry, I'm going to horribly botch your name. It's from Lunid Silna, and that is what type of confounders did we control for?
And so to help to alleviate concerns of confounders, we conducted a randomized control trial. And so we randomized diarrhea patient households based on the day that they came to the hospital and also the hospital ward to ensure we have balance across different variables. And I also should mention that we published this work recently in Clinical Infectious Diseases. And so there we go into more detail about our study design. But thank you for your question.
So we have another question about the surveillance for this study. And so how were new cases of diarrhea assessed throughout the study period? Was this through calls to the household or self-reporting from families?
So we conducted monthly clinical surveillance visits, and we obtained information on reported diarrhea from caregivers in the household. And I should also mention, based on our findings, that they come at a really relevant time based on the current COVID pandemic, because as public health practitioners, we're looking for ways to be able to send out behavioral recommendations around WASH and other behaviors. And so I would really like to emphasize that mobile health is a promising approach to do that, and also at low cost. To send out weekly messages to one phone for a year for our program was $2 US. And so it was very low cost. And many of the countries that we now work have high mobile phone coverage. And so this presents a promising approach. And I would like to also emphasize the importance of both the voice and the text messages, as I mentioned earlier, because one of the challenges with the voice messages is you're not able to save them. And so voice messages are good for people who can't read the text messages, but text messages have the advantage of being able to be shared with others. And we did see in our study that the message sharing was very high.
So we have another question, and so that is, were there any comments from the participants related to chlorine taste or odor?
Yes, so chlorine taste and odor is always a challenge. And so we had conducted a previous study where we had optimized the dosage of chlorine. So we found out the dosage of chlorine that was needed to deactivate the pathogens in the water, and in particular cholera. And so through that, we weren't having such a high amount that the taste was really strong. And also in our Bangladesh context, based on the work that the ICD-WASH group had done, we emphasized a vegetable, a bitter gourd that's eaten in Bangladesh. And we said, just like the bitter gourd is good for your health, but doesn't taste great, the chlorine has a funny taste, but is good and protects your health from getting diarrheal diseases. And so that's how we overcame the challenges with the taste of the chlorine. All right, so I have my email address here. And if you have other questions, I'll still be here to be able to answer any of them. Thank you. You can just add your questions to the chat box.
Thanks so much, everybody, for coming. And for those of you, if there are any that recently joined, we just saw a wonderful presentation from Christine Marie George and her research group on the CHOBI-7 mobile health program. And if you missed it or missed part of it, it'll be recorded like everything for this conference. And you should definitely watch it when you're done. So right now, we're going to switch programs a little bit to our work on drinking water chlorination, on antimicrobial resistance, and fecal microbiota. Can everybody see my screen? Should be able to see it. Okay, great. This is our team. We're a large group of collaborating institutions, including Tufts University, ICDDRB, Ramon y Cajul Hospital, University Hospital, Washington State University, and Stanford Woods Institute for the Environment. And we'd also like to take the time to acknowledge our funding from the Thrasher Research Fund. Without their support, this work wouldn't have been possible. I'd also like to thank the group at North Carolina for organizing this virtual conference. I know it's not easy, but I think they're doing a really wonderful job. So thanks a lot for that. So our overarching research question for our work is, what is the impact of water sanitation and hygiene on antimicrobial resistance and fecal microbiota? And how does this impact people and children's health? And there's a couple of mechanisms that we'll talk about a little bit later through reduction in exposure to pathogens and resistance, reductions in diarrheal disease, and antibiotic use. So that's what we'll be talking about in today's program. And it's split into two distinct specific aims. The first is focused on the impact of water chlorination on ESBL, E. coli, and Klebsiella carriage in children in Bangladesh. And this work is done in the context of a randomized controlled trial that Amy will talk more about in a moment. And we split the cohort into a treatment and a control group, and we tested them for these ESBL, E. coli carriage. The second specific aim that Maya will discuss is the impact of the RCT on the child gut microbiomes. And we sequenced about 130 fecal samples. And so Maya will talk about those results. And so that's the schedule. And then after you hear from Amy, myself, and Maya, Amin will wrap everything up and talk about the conclusions and the implications. But I also want to take the moment to say, we're going to do something interesting for the question and answer. There's this website here, pollev.com, with this link. And if you can all take a moment to go to this website, you'll see this box here, and any questions you have, you can ask here. And the cool thing about this is that then you can vote on other people's questions and answers. And so the questions that are most exciting kind of move to the top, and we'll answer those. And the questions at the bottom, we'll still answer those. So you can also find the link here at the website. And so with that, I'm going to turn control of my computer over to Amy. So Amy, please, after you.
Thanks, Tim. So I'm just going to talk about the original trial that this work has been nested into. And so this original trial was co-led by ICDRB in Bangladesh and Stanford University. And I just want to also acknowledge the amazing team that led this trial, and particularly Sonia and Andrew, who were in Bangladesh working on this for 3 years. And so the overall goal of this trial was to evaluate the effect of access to inline chlorinated water at the point of collection in Dhaka, Bangladesh, on child diarrhea. So the trial took place in two study sites, in Dhaka and in Tongi, which is a community, an urban community right outside of Dhaka. And in both sites, there was a piped municipal water network, but in both sites, the water was supplied intermittently, so it wasn't available 24/7. And when the water pipes are unpressurized, and that leads to contamination in the water supply. And in Dhaka, there were about 10 to 50 households sharing each of these water points. And in Tongi, there were several hundred households sharing each of these water points. And I wanted to note that in Dhaka, the intermittency was actually a bit worse, and water contamination was a bit worse at baseline at the start of the trial. So we did several years of formative research in the study sites before proceeding with this trial. And what we were looking for was a water treatment solution that met some ideal design criteria identified by users. So we wanted something that didn't require users to change the way that they were collecting water. We wanted a low-cost option, something that didn't require electricity, and that was compatible with intermittent supply. And provided a residual chlorine or chlorine residual for those households that were storing their water after collection. And so in-line-chlorination met all of these ideal design criteria. And I just want to talk a little bit about the technology that was used in this trial. So it was the Aquatabs Flow, which is a solid tablet doser. All of the water points in the trial had water storage tanks, which is actually quite common in Dhaka, to manage the intermittent supply. And so the doser was installed at the inlet of these tanks, and then users access the water by taps. And so the Aquatabs Flow doesn't require electricity, and it was compatible with very variable flow rates and gravity flow. And we adapted it to the water infrastructure in Dhaka. And I also wanted to note that in Dhaka and Tongi, people use their water source for all water needs in the household: drinking, cooking, cleaning. And so all of the water that these households were using was chlorinated. And so that's another reason why we thought that the work presented today would be interesting. So the study design was a cluster randomized controlled trial. We had 50 water points assigned to the treatment and 50 water points assigned to control. At baseline, there were around 500 children under 5 years old in each of the treatment groups. And it was an open cohort study. So because of the high migration rates in Dhaka, we allowed children to come in and out of the study throughout the trial. And if the health outcomes were measured among children living in compounds, in the study compounds. It was a blinded trial, so half the dosers were dosing chlorine, and half the dosers were dosing vitamin C. So throughout the trial, the chlorine dosing performance was quite good. We started out low on purpose. And then throughout the trial, over 80% of taps were delivering chlorinated water. And if you remove those water points where we had uninstallations for various reasons, 91% of the taps had chlorine residual when they were tested. We purposely dosed at a low chlorine residual because this is what we found to be acceptable in terms of taste in the study community. And we did see pretty big reductions in E. coli contamination at taps and in household stored water. So in terms of the impact of the intervention on child diarrhea, we did see an impact on children under 5 in the treatment group. We saw a 23% reduction in child diarrhea prevalence in the treatment group. This was actually more pronounced in the Dhaka study site, where water supply, if you remember, was more intermittent and of worse quality at baseline. And this is just showing you that we saw similar reductions regardless of how we define diarrhea in the study. So I also wanted to note a few additional impacts that we saw in the trial. And we saw an 11% reduction in healthcare costs. Children in the treatment group were 30% less likely to seek treatment for gastrointestinal illness. And most interesting and a motivation for this work being presented today, we also saw reduced antibiotic consumption among children under 5 in the treatment group. So this was a reduction reported among children reporting antibiotic usage in the past 2 months. And although it was a small reduction, it was statistically significant. And I also wanted to note that the original trial was funded by the World Bank, and I'm also listing here funders of the formative work that we did. And so now I'm going to turn it back over to Tim.
Thanks, Amy. So based on the results of Amy's trial, we put together this project where we thought if we have an effective WASH intervention, we might be able to look at the effectiveness on controlling antimicrobial resistant bacteria. And so first I'll talk about those results, and then Maya will talk about the results of the trial's impact on fecal microbiota. And so as many of us know, antimicrobial resistance is a global crisis. Failure to respond to the potential impact of antibiotic resistance could have profound health and economic consequences. This is in the context of a couple of different health crises right now, including, of course, coronavirus as well as climate change, but it's something that's really important. I'll also point out here that there's QR codes at the bottom of the screen if you want to find any of the references that are included in the next few slides. And so the high rates of antimicrobial resistance are also found in Bangladesh, the site of the study of the randomized controlled trial. And this is work done by collaborator Amin, where he looked at the colonization with ESBL producing E. coli among infants from 1 to 12 months of age. And he found E. coli present as early as 1 month, with over 80% of children colonized within 1 year, with the ESBL producing E. coli, as well as 3rd generation cephalosporin resistant E. coli and multi-drug resistant E. coli. And ESBL producing E. coli are a really important class of antibiotic resistance. People with these infections, if your infection is due to an ESBL producing E. coli versus a susceptible E. coli, you have higher rates of mortality, longer hospital stays, and increased likelihood of failure of treatment. So it's a really important class of antibiotic resistance. And so in controlling antimicrobial resistance, there's quite a lot of push and effort in global and national health plans, as well as in the scientific literature on WASH as a preventative measure that can slow the development and spread difficult to treat resistant infections. But there's actually very little experimental evidence. And so we're hoping to fill that data gap with this trial. And there's 2 potential mechanisms that Maya and colleagues put together in a nice review in Nature Microbiology that I highly encourage you all to look at, where this could work. And a WASH intervention could, for example, and we hope will reduce pathogens, which will lead to less diarrhea, which leads to less antibiotic use, which is what Amy found in her trial. and why we used Amy's trial to study this phenomenon, which can lead to reduced within-host resistant selection and carriage, and then hopefully reduce dissemination. So if fewer people have antibiotic resistance in their gut, it's less likely to enter the environment. But that's actually only one potential pathway. A second potential pathway is that the WASH can also reduce exposure to antimicrobial resistant bacteria. And then again, that can follow through the tract. And so to test our hypothesis, like I said, we need an effective intervention. And that's really what Amy's is it showed not only a reduction in diarrhea and a reduction in antibiotic use, but also high rates of antibiotic or chlorine in the water, as well as reduced E. coli concentrations in the water. And then I also take this moment again to suggest people go check out the poll EV if you have any questions. The link is on the website. So our main research aim is to look at what is the impact of this water point chlorination on carriage of ESBL producing Enterobacteriaceae. And to do this, we collected the feces of the children from the control and the treatment group, and we plated them on chromide agar, which can allow us to identify ESBL producing E. coli and Klebsiella. We also conducted an enrichment. If the quantities were too low to count, we would look for an enrichment to help us distinguish positive prevalence versus not detected. We also sequenced a subset of the E. coli isolates. And so what we found is that ESBL E. coli prevalence is not statistically significant between those children receiving chlorinated water and those not. There was a 6.5% higher prevalence in the control relative to the treatment group, but when you control for study site and age, the relative risk was only 1.02. Similarly, there was no significant difference on the concentration between the two groups. When we looked at ESBL Klebsiella, which was not the primary outcome, but a secondary outcome, that was also not significantly different. Control had 3% higher prevalence, and average was around 11.5%. And the relative risk was 1.32, but incorporated 1 in the confidence interval. And then also, again, the control had no significant impact on concentrations. So outside of the scope of the randomized controlled trial, we also looked at other potential risk factors, and 2 that were significant are study site, where Dhaka versus Tongi, Dhaka had a lower relative risk versus Tongi. And so that shows that the environment likely plays a role in the carriage rates of ESBL E. coli. And then also age, with increasing age, statistically significantly more likely to carry ESBL E. coli. Looking at the sequencing data, we were able to track the genes most prevalent within the treatment and control. And we found CTXM and TEM are the most prevalent genes. Notably, TEM was more prevalent in the control isolates than the treatment group. And so some more of Amin's work talks about how a lot of these resistance mechanisms can be spread through drinking water. So it's possible, and the perceived mechanism would be that chlorination could help reduce exposure. And so the takeaway is that an effective WASH intervention does not significantly impact fecal carriage rates of ESBL producing Enterobacteriaceae, which was a little bit disappointing. We were hoping to have another tool to help fight AMR and to build the evidence base around here. But I also want to point out that the word significantly. So we did see a 7% reduction in ESBL E. coli. The study was powered for a 12% reduction. And a 7% reduction is about the annual increase in ESBL carriage rate from, I think, 2000 to 2013 from a seminal paper by Werther et al. That maybe you have seen. And so with that, we're going to talk about the conclusions, the interpretation of this at the very end. Amin will take over that when he synthesizes and synergizes the 2 talks. But for now, I'm going to turn over the control to Maya, who will talk about the fecal microbiota.
Thanks, Tim. So we're going to switch gears a little bit and talk about the impacts of this intervention on the gut microbiome. Is this working? There we go. So when I refer to the gut microbiome, what I'm referring to is the trillions of microorganisms that live within our guts, including bacteria, viruses, and also fungi. Now, bacteria in particular are critical for digestion and nutrient absorption, but the microbiome as a whole has a role in regulating our immune responses, weight gain, and even our mental health. Now, our gut microbiomes develop over the first few years of life through the age of 3, after which they achieve what we refer to as a stable adult-like state. So over these first few years, our microbiomes become increasingly diverse, and we see different families of bacteria dominating the gut during that time. Now, we know that this normal process of gut microbiome development can be disrupted by frequent pathogen exposure as well as antibiotic exposures. And at least in Western settings, we know that abnormal gut microbiome development increases your risks later in life of developing obesity, allergic disease, and asthma. Water chlorination could potentially impact the gut microbiome in multiple ways. So first, water chlorination, of course, could reduce your exposure to diarrheal pathogens, which in turn could reduce your demand for antibiotics. And again, as a reminder, both of these outcomes were observed in the original trial that Amy described. In addition, it's thought that frequent exposure to pathogens results in chronic gut inflammation. So by reducing exposure to pathogens, water chlorination could also reduce this effect as well. At the same time, if you're drinking chlorinated water, you are ingesting a small chlorine residual. And you're also consuming an altered water microbiome. So water chlorination does not eliminate all bacteria present in water. And this could result in a bias in the types or diversity of bacteria that you are ingesting through water. And of course, all of these factors impact the gut microbiome. So we had 2 objectives with this study. The first was to determine the impact of water chlorination on the relative abundance of children's gut bacteria, as well as to determine the impacts on the gut resistome. And by resistome, what I'm referring to is the collection of antibiotic resistance genes harbored by all bacteria in the gut, both pathogenic and non-pathogenic. So we analyzed stool samples that were collected following at least 6 months of the intervention. And we selected samples based on age. And we used these age bins described here. And we chose this based on a study of over 1,000 children from the US and Europe that found that these specific ages corresponded to distinct phases of microbiome development. We also stratified our sample selection by study site, and we randomly selected samples for short-read metagenomic sequencing. We sequenced 130 stool samples in total, 66 from the treatment group and 64 from the control. And we achieved almost 40 million reads per sample. And the results I'm going to show you now have been controlled for both age, those age bins I described, as well as study site. So first, we did find that water chlorination significantly influenced the gut microbiome. Specifically, we saw clear shifts in 21 bacterial genera. So we found that 18 genera were less abundant among children receiving chlorinated water. So the way this graphic is set up, each of these rows here corresponds to one of these 18 genera. And what I'm depicting is the percent difference in the relative abundance of each of these bacteria between treatment and controls. So these values are negative because we're talking about bacteria that were less abundant among treatment children. So for 17 of these 18 genera, these were bacteria that are typically described in environmental media, such as water and soil. We did not see reductions in any bacteria that's commonly associated with clinical infections. However, we did see reductions in one animal pathogen, Coxiella. So Coxiella comprises only one species, Coxiella burnetii. And this is actually the causative agent of Q fever, which is primarily an animal disease infecting sheep and cattle and goats, but it can also cause human infections. And so this finding suggests that children receiving chlorinated water might have been less exposed to water contaminated by animal feces. We also found that some genera were relatively more abundant among children receiving chlorinated water. And so there are a couple of reasons why this might happen, and I'm going to walk you through just one scenario, which is ecological niche expansion. So let's pretend that these different shapes here represent different types of commensal bacteria living in a child's gut. And you can see this child is also infected with pathogens. Now, if that child began to receive chlorinated water, we would expect to see a reduction in pathogens that would otherwise colonize the gut. And this leaves more space and especially more nutrients for gut commensals to take advantage of. So gut commensals can proliferate and occupy this new niche, resulting in a higher relative abundance of some gut commensals in the treatment group compared to baseline. So keeping that scenario in mind, we found 3 genera that were more abundant among treatment children, including Escherichia. So certainly some strains of Escherichia are pathogenic, but for the most part, these strains are gut commensals and they're commonly described in the human gut. We also found that Flavinofractor were more abundant. This again is another type of bacteria that's commonly described in the human gut. And we also saw increases in Arsenicococcus. This was kind of a more bizarre finding. So these bacteria are typically reported in environmental media that have been contaminated by arsenic, therefore the name. So as many of you I'm sure know, arsenic contamination of groundwater is a pretty pervasive issue in Bangladesh. And so we think this is potentially a very context-specific finding. So we've just begun to conduct subgroup analyses to examine the impacts of the intervention on these different age bins. What we're finding so far is that among these older children, the trends in terms of bacteria that were impacted by the intervention, those are very similar to what I've already described to you. However, among the very youngest children, we're seeing quite different impacts. So we're finding that 13 taxa are less abundant among these children, while 28 are more abundant. And we're seeing reductions in known pathogens, which is interesting, including Campylobacter and Streptococcus. However, we're also seeing reductions in known gut commensals like Bifidobacteria and Lactococcus. So clearly we have a lot to unpack here. I want to point out that a very important caveat of these results is our much smaller sample size. We only have 27 kids in this very young age group. Another important caveat for our findings overall is that we could not assign taxonomy for a substantial percentage of reads in many of our samples. And so what we think this is a result of is a potential high income country bias in taxonomic databases. So many of these taxonomic databases have been informed by sequencing studies that have mostly been conducted in high income Western settings. And so what we're finding, especially among our older children, is that we really don't know what organisms, a substantial percentage of the organisms that are colonizing these kids, we don't know what those are. So that's something we're going to be exploring in future work. Moving on to our second objective, which was determine the impacts of the intervention on the gut resistome. So I described to you earlier that Escherichia were relatively more abundant among treatment children. That was true for the family of Enterobacteria in general. And this was interesting because Enterobacteria frequently encode antibiotic resistance genes. So because of this, we were interested in exploring potential impacts on the resistome. Briefly, although resistance genes were exceptionally common among children in this study, we did not find any difference in the relative abundance of any antibiotic resistance gene between treatment and control children. And Amin and Esther are gonna kind of go through some reasons why that might be. So to conclude, we found that water chlorination significantly impacted children's gut microbiomes. We saw differences in pathogens, commensals, and environmental bacteria. And our preliminary results thus far indicate that very youngest children might have been differentially impacted by this intervention. However, we did not observe clear impacts on the abundance of any of the antibiotic resistance genes we looked at. And with that, I'll turn it over to Amin.
Thank you, team, Amy and Maya. Can I take the control of the slides?
Mm-hmm. You should be able to click through now.
Okay. Yeah, okay. So thanks everybody. So Based on the findings of this study, I think we can conclude that the in-line chlorination of drinking water source in the community does not significantly impact fecal carriage of extended spectrum beta-lactamase producing Enterobacteriaceae among children, although we have got some differences in the carriage rates between the treatment and control group, as Tim mentioned. Similarly, we also didn't find any clear impacts of the in-line chlorination on the prevalence and abundance of antimicrobial resistant genes of the fecal registome. But as Maya mentioned that we have got some effects on the composition of gut microbiota. How do we explain these results basically? I mean, obviously it is possible that there is no effect of in-line chlorination of drinking water on fecal carriage of AMR among those children, but thinking about the routes of exposure, to these antimicrobial resistant organisms, you can see there are multiple routes of exposure, and providing only the clean water may not be sufficient to make a significant impact on fecal registome. And the other routes which are very important to consider how the antimicrobial resistant bacteria can transmit to the children's are inadequate sanitation facilities, lack of hygienic practices, and then the consumption of contaminated foods, and overall living in a contaminated environment. And certainly all these conditions are commonly present in our study setting. And the other reason might be the duration of interventions for this study, and which we think that might not be sufficient to replace the antimicrobial resistant bacteria from the gut with the susceptible one, or just to wash out the AMR organisms in the gut. And this might also related to the open cohort design that Amy mentioned. Certainly all children were not enrolled throughout this study. Now, considering the findings of this study, how our future study will look like, we can definitely look for the impacts of other WASH intervention strategies like the sanitation and hand hygiene and household safe supply of safe drinking water to the households individually or in combination, and see the fecal carriers of AMR in different geographical locations which have the similar settings. And we can also identify the potential predictors for the effectiveness of WASH interventions on a carriage of AMR and gut microbiome, the changes of gut microbiome. Yeah. So that's all from my side, and I will turn it to Tim for the question and answer session.
Thanks, Amin, and thanks to all the presenters. Another acknowledgement of the collaborators and collaborating institutions, and again, the Thrasher Research Fund for funding this project. I now encourage you all to go look at this website, polev.com. If you could enter this in or link it from the chat box, then we'll be able to switch over to those questions now. And in addition, if you have any comments, you can contact any of the presenters. So with that, I will now pull up the PoleEV website, which you should be able to see here. So you can, of course, add in the chat, or if you just go to Files, click here, the Pole Everywhere right here will show up. And now we have sort of a set of questions that Esther will coordinate. So thanks, Esther.
Yes, so everyone, just feel free to enter your questions. We have one question for now, which is, what do you think about the selective pressure provided by chlorination? And then there's a comment about removal of bacteria and relative abundance. of antimicrobial resistant bacteria. So maybe Maya, you'd like to answer this question?
Sure. I guess it's hard to comment on the selective pressure provided by chlorination beyond what the person who asked the question has stated. There's actually very little information about the impact of chlorination on the gut microbiome. You can imagine it's pretty hard to do randomized control trials on this. Most of the studies that we found were conducted in mice. So it's hard for me to comment on, common themes that we might have expected in our findings based on chlorination. Tim or Amy, do you have anything to add to that?
I mean, I did have one comment to add related to interpreting these results more broadly, which is that in the treatment group, we still had 40% of children reporting consuming antibiotics in the past 2 months. So although this trial did reduce antibiotic consumption, it was still really, really high in the treatment group at the end of the trial. And I think that needs to be considered when we're interpreting these results.
Okay, maybe Amy, you can take the next question, which is regarding more to the trial itself. So it's what kind of household water storage methods were utilized in the in-line chlorination work?
Yeah, so households stored the water the way they typically would. So in containers, usually 10 to 20 liter containers. But one thing that we did measure was the time of storage in the trial, and it was pretty short. So households were storing their water, I think on average less than 6 hours. So it was pretty short storage times overall. And Amin might have something more to add to that.
Another popular question is, why was chlorination chosen as opposed to other water treatment methods? I think that would probably also be for you, Amy.
Sure, yeah, so we chose in-line chlorination because it was a great fit for the study context. And we chose a technology that would basically provide treated water by default out of the tap, which was very important to us. So what we wanted to do was choose a method that would really minimize the user burden in this population and not put the burden of consistent usage on the households. So we chose chlorination because it's highly effective at reducing most bacteria and viruses, and because the water turbidity in these systems is actually fairly low, so chlorination is an appropriate disinfection method. And it's also very, very inexpensive. Chlorination is one of the lowest cost ways to disinfect water.
And are there any further plans to do comparisons to water filtration or other treatment methods? Maybe also Amin has ideas, because you mentioned.
Yeah, I mean, maybe you can take this one.
So the comparison to the filtration methods. Yeah, so basically, I mean, what we have done in our study is the in-line chlorination of the sources of water, but we can also look for the, the household-based supply of safe water. Like, I mean, this was in the community setup. So if we can, we can also plan for individual household level supply of safe drinking water, and we can also see the effect of the consumption of drinking water, we can ensure that the household members are provided with the safe drinking water at the household level, and we can also test those to see the effect on the gut microbiome and antimicrobial resistant carriage.
Thank you. There's one final question, which is, were Genera comparisons adjusted for multiple testing? Maya, I think that's your one.
Yeah, so my apologies for everyone who was interested in the microbiome data analysis methods, because I didn't mention them at all because I ran out of time. But if you have further questions beyond this one, feel free to reach out to me. They were adjusted for multiple testing. We used an R package called corn cob to do the analyses that I presented to you.
Well, thank you everyone for coming. With that, we close the session in the next minute. So if there's any other pressing or exciting questions, feel free to add them to the poll EV. And otherwise, please feel free to reach out to any of us for any questions individually. We're all registered participants in this conference, and hopefully we'll see you in some of the other sessions. And thank you again for your time. And again, I encourage your colleagues to watch the recording to see Christine Marie George's presentation on the CHOBI 7 program, or to watch ours or to rewatch ours. So thanks again, everybody. Bye.
Thanks, everyone.
Thank you.
Thank you.